that I'm really thankful for this weekly meeting. It fulfills me as much as I hope some of you, and I can't imagine a better group of people to do that with. So thank you. And I want to thank Terry, just constantly working hard behind the scenes, and this pandemic has really brought that out, but it's something that she does each and every day in the chapter as a whole, before, during, and after the pandemic. So I want to thank you, Terry, and the chapter. And I want to thank Representative Schofield and Chris Reed. This Georgia Council on Lupus Education and Awareness is one of the few states, we are one of the few states in the country that actually has a governor, state-sponsored council on lupus education and awareness. I don't know if you knew that or not. And so I want to thank them. And my team and I do a lot over at Emory and at Grady specifically, but one of our big projects is called Goal, and I know many of you are participants in that, and want to thank you so much for all your contributions. And I think I'm sad that it's come to this, but Goal has been made for this time and situation, and everything we've worked over many years, I think, has really come to a head, and it's going to provide some amazing information leading forward. So thank you. So these are the figures, latest worldwide figures, and no major changes from last week, other than the UK actually went down a few spots, and India, Spain, Peru, and Chile have gone up, and Mexico jumped up there. But in terms of what the world is doing, this is the hotspot map that I showed last week. And you can see that the US is, as a whole, now there's a lot of variations I've been mentioning, pretty much the same. And then the hotspots were kind of in the large parts of South America, Mexico. You can see smatterings throughout Africa and India. So this is where we are this week. The US is definitely rising. Big parts of South America continue to rise. Paraguay is a really hot spot. And as I said before, there's going to be constant ebbs and flows for these hotspots. It's a whack-a-mole. You're going to put out a fire here and it pops up elsewhere, and that's the nature of the beast. So we can never fully relax. And that's in part what you're seeing here in a way. But you do see some areas in South Africa, Kazakhstan, and interestingly, Australia is really starting to ramp up. Now, remember, the Southern Hemisphere, everything south of where I'm drawing a line across, is in the winter. And so people tend to be more congregated because it's cold outside, and that's when the flu also starts circulating and other viruses because of those issues. So it kind of gives you a little peek, I think, of what we're going to deal with this coming fall and winter too. Can you guys see my screen? I thought I was showing that. Can somebody in the chat confirm, or okay? Thank you. I saw a note there that okay. So this is this week, and then this is new reported cases on the top, and you can see over the US that we're definitely on an upslope. Now the deaths are going to lag. They're at least 2 weeks behind. I imagine that the uptick in deaths won't be as great as what we saw before, assuming that most of the new cases stay in the relatively younger people. But you're seeing plenty of stories of young people and middle-aged people without major issues get really sick. So and it's just a matter of time before the young pass it on to other people too that can get really sick. So everybody fully expects that the death curve will start going up, unfortunately, probably in about a week or two. But certainly, if you look at the new cases, I mean, it really is a shame to work so hard to flatten the curve. And I argued in the past, we really didn't flatten the curve. I mean, we're just sort of, I mean, that's not true. We never went down on a curve. We merely flattened it. And now we're just going even higher than we were before. But that's where we are now. And this is a map of the hotspots from last week that I showed. Just let you get a sense of the country there. And this is this week. So from previous week to this week, you can see that there's generally the same principle that out west and in the southeast are the big hotspots, but it continues throughout the eastern part of the United States, very large areas of increased cases. And then you can see, especially around our area in Atlanta and Georgia, that just all parts are starting to get covered with increased number of cases. And again, this is what we predicted and was afraid that would happen with the states opening up, and probably a large part in terms of some of the protests that were going on and the people that were not protecting themselves as well as they should. So speaking of masking, when we look at the state in terms of the hotspots, and yellow and red are very little to no masking requirements, it doesn't really make sense to me that you're getting a lot of cases, but you don't have mandated masking. And so I get it. I think there are some people that really are on the side of individual liberties, if you will, and really asking people to mask for the sake of everyone else. But it isn't working. The reality is that there are many people like many of us who are very careful, but it takes just a few people to not do that and really spread the disease. And where it's spreading is all over in terms of the states. I mean, this is just a recapitulation of what I showed earlier. Now in Georgia, there are more areas that are becoming hotspots. So I think the majority of the counties, it seems like, are on the uptick. Certainly in and around the metro Atlanta area, all the counties are increasing. And then unfortunately, continuing in the rural areas down south, there are increased cases. And this was last week. Now, I mean, look at what's happened even more. So just take the concern from last week to increased amounts all over Atlanta, outside of Atlanta, north, south, east, and west, especially along the coast. It really is a big issue. So that begs questions like this, and I appreciate the question. Was it a mistake to open Georgia so soon? Should we be going back to lockdown with higher numbers? Do people need to be more careful? I mentioned before that that being careful shouldn't really depend on whether you're in a hotspot or not. And even if you were in a county where it shows that there were declining cases, the reality is that people will continue to get infected. People travel. There are going to be cases from outside of that county. You just never know. And we all travel outside of our own counties to work, to live, to visit. So that shouldn't change no matter what. Now, was it a mistake to open Georgia so soon? I mean, this is the balance between public health and business. And I mentioned before that opening is a business solution, is a business decision. And so what level are we willing to accept infections and a certain number of deaths to offset the devastation of the pandemic on the economies and people's livelihoods. And so, uh, there are a million different opinions about this, but I think what hopefully we're all learning through this is that we just can't relax. I think there was a lot of human complacency that occurred after the initial rise, and we saw the numbers going down and businesses were opening up. And when you're just not attuned to all these issues as much and able to get back and do the things that you just did a few months ago with such happiness, and the weather is getting warmer, so it's tough. And we know that now, hopefully, people will understand before it gets way too late that as even the weather gets better, the virus doesn't go away. So we just need to find that sweet spot, which will not be appropriate for everybody. The reality is there's not a magic sweet spot, but there's going to be some point where all sides give and take. And that's where we're struggling to find as a community, as a state, as a country. Um, but I do think that because of slides like this, where you just don't see a total flattening. I mean, you see some, but I mean, it's going back up, and you need things to go way down. The European countries are way down. That's why they're opening the borders between European countries, allowing more tourism, because they've spent that extra time and they've committed as a people in a united fashion to really mask and protect one another and to bring the numbers down. And if you have curves like this, you just can't go forward. And it's going to get to the point where we do have a lockdown. And the question about the lockdown is not necessarily with the higher numbers, it's really higher numbers specifically as it relates to overwhelming the medical system. When we don't have enough ICU beds and especially ventilators for the really, really sick, then that's when we have to institute a um, a legal sort of lockdown where we force people to stay, because just asking nicely, pleading, having many messages on the public are just not bringing the cases down. And so therefore the number of severe cases continue to go up. The general situation in Atlanta has been that there are more and more cases that are requiring hospitalization. The ICU capacity is nearing full in many hospitals. And there are a couple of reasons for this, actually. One is the rising number of COVID. But what you may be seeing or reading about are the tremendous number of violent crime, especially gunshot wounds that have been occurring. And it's crazy, how busy Grady is, and being the level 1 trauma center in Atlanta. They had the busiest month last month for gunshot wounds in its history. I mean, we're talking a long period of time. We've been through a lot as a city and a community and a state, but they had the most number. And so a decent percentage of the ICU at Grady is filled with other people, especially gunshot wounds, and those who have chronic conditions that just didn't seek care or had difficulty getting care during the early part of the pandemic. So they got even sicker. So there are a lot of other people that are needing the advanced care, along with rising cases of COVID, and that just equals less availability. We're not to the point where we're starting to hear about in other places like Texas, where there's a dire need, and there are flashbacks to the pictures that we're seeing very early on in places like Italy and in Spain. But here we are many months after that, knowing what we know, to be in that situation as a country again is just it's very disappointing. This didn't make too big of a news, and I think everybody's just so attuned to how they're feeling anyway. But FYI, the CDC did add 3 categories to their list of COVID-like symptoms. So again, these things don't equal COVID specifically, but if you are having some of these symptoms, then it may be worth getting tested or making sure that you're not around too many other people. So in addition to the fever, chills, cough, shortness of breath, fatigue, muscle aches, headaches, loss of taste or smell, and sore throat, they added congestion or runny nose, nausea, which is interesting, and diarrhea as well. So those were mentioned earlier on, but they were not on the official CDC list. And so I think they've gotten enough numbers to get a sense that a decent percentage of people with COVID can get that. It's not the most common, these things, but, and the ones on the left are definitely more. I mean, the fever, the achiness, I mean, those are the things that you really worry about. And as we get into the cold season, you're going to get a lot of these other things like congestion. But definitely keep this in mind. Because we're not able to really bring the numbers down, we're just having to extend some emergency measures that were instituted initially for the early parts of the pandemic. But the good news out of this one is that there's an intention by the Health and Hospital Administration as part of the federal government to extend a public health emergency that was set to expire on July 25th. And what that does for people like healthcare providers and hospitals, it allows us to do telemedicine in a way that we couldn't do very easily before, and to bill to a certain extent. I think those are some of the main ones that I know of, and I'm sure there are other things that this will facilitate. So that's good, but it's bad that we have to even extend this because the emergency continues. I don't know if you saw this or not. It was a very nice study. I was waiting for somebody to do something like this. This is Florida Atlantic University, and they have mannequins that they put and vaporized aerosol into, kind of simulating what we would cough out or breathe out normally. And they put different maskings on it, and they shone lasers throughout the field so that even the smallest drop would light up because of the laser field that they lit through it. So I'm just going to show this video here. This is an open cough. And this is in a completely quiet room, still air. You get a sense of the person's width, and you can see how far away the droplets go in still air. And this is in real time so far, and you can see how it just stays in the air. And even when they speed it up 4 times, it just remains in the air. Now this is very, very still air. So when you're out in the outdoors, then you have a lot of current air. It disperses the drops, which sends them further. But on the other hand, you're in wide open spaces. So when they're dispersed, they're very small in concentration. There's relatively few droplets. So that's why the risk when you're outside, if you maintain social distance, even though the droplets may theoretically go further, they're going all over the place because of the winds outdoor, and chances are much smaller that you'll get any significant amount on you and that you will breathe in and get infected. Now, if you're in a closed space with some crosswinds, and you might have heard about some instances where people have gotten infected from several tables away because of the air conditioning current. So when you have a meal that's an hour, hour and a half long, and you have that constant exposure to the droplets, even though they're being dispersed by the air conditioner, but they're being kind of thrown right at you. I mean, these are the issues that you have to think about. And there's no mask being worn by either party. You can kind of sense how easily one would be able to get exposed and therefore infected. Now, they did this interesting one where they put different masks on, and you get a sense of how well they work. And this is a homemade bandana. It's just a fabric, basic scarf. Not as good, but it does disperse some around the face. And as a whole, it doesn't get as far as an open mouth, but it's not as good. Now, if you just take some fabric, fold it over a few times, do a pleated face mask, so you see some coming up, but definitely not as much as that bandana, and certainly a wide open mouth. And yes, it does come out, but it's relatively close to you. So if you were to maintain social distancing, you wouldn't get exposed. That's why we say that the masks are more, they protect others more than they protect you, but they do protect you too. Here you see higher grades, a stitched mask earlier. This is a professional grade face mask. So can you imagine if everybody in a room had a decent mask and we were protecting each other and you maintain some social distance? Can you see how effective that would be? How utterly powerful that is in terms of this aerosol related virus. This is a respiratory virus. It lives completely on its ability to go from an infected respiratory tract into another respiratory tract that's infected. In other words, the droplets have to go primarily through the air and breathed in by someone else. Yes, you can touch a surface and then touch your nose too. But when you're talking about a bar and a protest and a concert, I mean, these are the droplets that are everywhere. So please, please, I know many of you are protecting yourself, but how much greater would the effect be if those around us would have masks? Now, one thing I'm just gonna bring up now that I'll probably I will go into deeper down the road, but it got me thinking. We talked about the vaccines that are being developed, and there are about 3 or 4 throughout the world that have a high chance, it looks like, that at least one of them will be approved and have some decent efficacy. And we may even get some health workers to be the first ones to get access to it, maybe in the winter. And hopefully by the spring, by next summer at the latest, we'll have it generally available. Now, a lot can happen still, but what I'm hearing is that people are still very optimistic about this timeline, which is amazing. And given how tremendous COVID has been to everybody, I just initially assumed, I had this implicit bias that people would be all over the vaccine, but I was reminded through stories like this of how strong the anti-vaccine sentiment is. And I've been allowing a lot of this to happen, and I think my colleagues have too. But I'll just speak for myself, but I can say that a lot of other doctors are too, because of the well-known and poor immunization rates for especially the flu and the pneumonia vaccines in people with lupus and other rheumatologic conditions. So even before the severity of COVID and the impact of the pandemic, when we knew about effective vaccines, They were out there available for people that have compromised immune systems such as lupus. And yet the vaccination rate was very poor. And there were a lot of factors here. There's things in the healthcare system. I don't think we do a good enough job in offering it to everybody regularly, educating, really making it a priority to discuss it and to provide for it before someone leaves the office. But there were many other times too, when even after I presented it, there are people that just refuse to get it. And I'm not here to judge by any means, and I'm not thinking about anybody specifically. And there are good reasons to not get a vaccine in some people, but I will tell you that the legitimate reasons scientifically are relatively small. And Lord willing, there is going to be a time soon when there's a vaccine out there. And to know that there's a decent percentage of you all who will not get that vaccine for a variety of reasons, you know, at the end of the day, I've always believed that, and I hope my patients can support me on this. You know, I've never made anybody feel badly about their decisions, but the reason people come is for me to give my opinions. And at the end of the day, you make your own decisions. But I need to better educate. We all need to do that as a job, the scientific community, medical community, about what a vaccine is and what a vaccine isn't. And you all come every week, and I think some of you may be in this boat, but maybe you know some friends, family members are in the same arena where they have this concern. We need to get ahead of this, because when the vaccine does come out, you need to be really prepared to make the best decision that you can. And we can't continue to have people not protected if they're using reasoning that's not sound. So I will come back to this, and I would love to hear people's perspective on vaccines. And again, at the end of the day, if even after I'm preaching to you, if you decide not to do it, you know, I will always respect and care for you. But I think there are, when I corner people as to the reasoning behind it, at the end of the day, you can just say, you know what, I'm afraid, and no matter what you tell me, I'm not going to take it. That's fine. But don't give me a reason that's not rational. And we're going to go over this together over the next few weeks. A new study from Michigan said that hydroxychloroquine decreased the death rate for people with COVID by 50%. Is this a reliable study? And are we going to have shortage of shortage for lupus again? So the study that is being referenced, oh, sorry, I put that in the wrong place, is this one. It's out of Henry Ford Health System, which is in Detroit, Southeast Michigan. They look back at their hospitalized patients, over 2,500 of them. And at the end of the day, they found that people who were given hydroxychloroquine were much less likely to die. So this is what we call a retrospective study. And I mentioned to you that there's a lot of issues with retrospective studies. They're not as powerful as prospective, especially double-blind, randomized, controlled trials. So going forward, saying, okay, we're going to start this study on this day now, and we're going to control the environment, randomize who gets what. We're going to blind people so they don't, I mean, not literally blind, but they don't know whether they're on the real drug or not. And then we're going to see at the end of the day what changed. That is really the strongest level of evidence. A retrospective study is when we go back in time. And you have to remember, people were put on Plaquenil for a lot of reasons. And the people who were not put on Plaquenil back before were not put on Plaquenil for a variety of reasons. And those are what we call biases. And it's just not as strong. But after a string of negative even retrospective studies for hydroxychloroquine comes this group that published in this journal. And they saw that overall, in these over 2,500 hospitalized people in Michigan, that there was a death rate about 18%. And those that were just on Plaquenil alone, the death rate was 13.5%. Those on hydroxychloroquine and azithromycin had a death rate of 20.1%. And those on azithromycin alone had a death rate of 22.4%. Those who were not on Plaquenil or azithromycin had a death rate of 26.4%. So when you look at 13.5% death rate for Plaquenil alone and 26.4% death rate for not being on either Plaquenil or azithromycin, it gives you a sense that there may be some impact of hydroxychloroquine. But again, we don't know if the people who would have done well anyway, those are the ones that got hydroxychloroquine. But this is a study that flies in the face of a few others that were negative before. So it all gives us pause. And the researchers here point out that even though it's not the strongest of studies, they do acknowledge some of the biases, as I mentioned. They also mentioned that perhaps the use of the steroid dexamethasone that has been getting a lot of press about being effective in especially the people that are really starting to get sick. That might have accounted for better survival in some of the patients, and maybe those were the people on hydroxychloroquine. So if you get hydroxychloroquine, I mean, those are people and or doctors who are just going to be more aggressive, right, compared to those that are not on anything. And maybe those that are more aggressive in terms of their treatment would have gotten dexamethasone, and that's why they got better, and not really the hydroxychloroquine itself. But on the other hand, they do point out that that the patients in this study seem to have been treated with hydroxychloroquine earlier as a whole. And their point is that maybe this points to how hydroxychloroquine should be instituted earlier, whereas all the other studies that were retrospective, that were negative before, started the hydroxychloroquine much later. So again, this is as the world turns, the soap opera of hydroxychloroquine. 1 week it's in, next week it's out, another week it's partially back in. Again, I think these prospective, randomized, double-blind, placebo-controlled trials that I mentioned that are really the strongest, they're the ones that are still ongoing at this moment, and they're still active. And so we'll know better in the time to come. There was a question about the differences in how they call cases, confirmed or probable. And yes, states are doing a bunch of tricks, and we've mentioned this in previous town halls about padding numbers favorably in different ways. But to the question about what is a probable case, so a confirmed case is one that has a positive test, right? So a probable case is one that doesn't have a positive test, but has other suggestive features. So here you see a probable case is someone that does not have a confirmatory laboratory test, but they meet some clinical criteria. They have fevers that can't explain by anything else. They have cough. They were exposed, but they only had one test done. And these tests are not perfect. And even though it was negative, so that's a probable case. So here, I mean, these are different flavors of that. There's a laboratory test that's presumptive. It's not clear positive, but it's probably somewhere in the middle. And there are some clinical criteria. The person's sick, has fevers. So probable are just shades of gray. There's enough to be suggestive, but we don't have an absolute positive confirmatory laboratory test. Is it safe for lupus patients to go back to work or the office? Do you recommend to work from home as long as possible? In an ideal world, I think given people with lupus have an immune condition, if you can work at home, if you can be away from people, where you can be in a more controlled environment, that's the ideal situation. But as I mentioned in the past, there's so many other variables. And again, this isn't going to go away anytime soon. So and people need to put food on their tables. So I just want to remind people of some of the slides I've showed in the past. Corona is not going anywhere. So you have to protect yourself. You have to avoid those who are sick, socially distance, wear masks, sanitize, don't touch your eyes, nose, and mouth after being out in the public. And reopening business or going back to work is a business decision, it's a financial decision. It means that your employer needs you to go back or is asking you to go back because that's where he or she feels that you would be the most effective, or you have a job that can only be done in person. This has nothing to do with the virus itself. It's a business decision. But you can protect yourself, hopefully, in any situation. You have to maximize that opportunity. So if you do have to go back to work, you have to think about, are you going to be potentially around people that are exposed or sick? Are you able to socially distance and have the materials and the barriers to protect yourself? Are you able to wash your hands? Can you avoid touching sensitive areas of your body? So these are all things that you have to think about when you return. And so there is no such thing as safe or not safe. And so therefore I can't tell someone you can go back to work or don't go back to work. You can only talk about, well, gosh, hearing about your job and what you have to do and what your employer is offering and how long you have to be there and how little protective equipment you have, your situation seems to be much less safe than most. And so how badly do you need to go back to work? What other opportunities do you have? Who else is going to be at home that potentially can be exposed? I know there's so much to think about, but I mean, these are answers that nobody can just give you simply. You have to really put all this together. So the decision-making rules are this: remember your COVID facts. The virus isn't going anywhere. People walking around, going to the stores, you being asked to go back to work, it doesn't mean that things are better. It would be better if COVID went away, but the virus is still around. You're going back to work or being asked to go back to work. Things are opening because it's a business decision. So can you protect yourself? And you just have to get a sense of what your line is. So for each decision about whether you do it or not, you have to weigh the risks against the benefits. How necessary is the activity? How well can you protect yourself? And how well will others behave? And that's something that you can't control, but you might have some idea as to that, because you can do everything right, but that can all be offset if you're just not in a really good environment. Last one here, what are your recommendations for students that are returning to school who have lupus or parents of children who have lupus? To be more specific, is it okay for the child with lupus to go to school if he or she wears a mask, but social distancing and mask is not enforced at the school? Well, I think if the child has lupus or the parents of the child has lupus, you're at higher risk. I mean, it's clearly that. And in an ideal world, I would not want to be exposed or be at greater risk by going back to school, because I think school undoubtedly will be greater risk. But again, just as I've talked in the past few slides, I've come to appreciate just how integral school is in people's lives. To be able to go back to work for some parents who desperately need to have that income. Even homeschooling for some districts are just so tough. And what other siblings will be around, and what's the home environment? And I just hear, I've heard such sad stories of people that are just struggling so much at home, and it's just so overwhelming. And so and children certainly don't learn as well, um, ideally anyway, in a remote environment compared to in-person teaching. And the social aspects of going back to school are so important. This is such a tough call. I do know a lot of places are different options, and you can kind of try one out. And I think generally speaking, I would tend to be more conservative. I think it'll be very tough to have a school with significant um, safety practices that are consistently in place. And by that I mean those mannequins and where you can see the aerosol droplets from their mouths. I mean, that's in an ideal situation where it's covering their nose, and so a lot of kids, it's tough to keep anything on their face that's really um, covering all the areas well for a consistent period of time. And then it's really to protect other people. So what you want is your child to be protected from others. And so you want other people all around you to be masked just as well, if not better. And so if the enforcement isn't going to be as good, and other children I mean, the degree to which they adhere to the rules are just going to be all over the place. And that's what children are. It's going to be very tough in how closely confined the halls will be, even if you do have some way to try to maximize the distance. There's no question it's just not going to be ideal. But on the other hand, like I said, it's a matter of risk, weighing risk versus benefit. And there's just so much benefit for some people of returning to school that yes, my general recommendation in an ideal world is that going back to school is going to be more risk, but it's just like going back to work. And how can I say that when it's easy for me to say that? I don't have young children where they need to be watched and I have to stay home. Mine are old enough that I don't have to worry about that. And I don't have to work this coming week in order to put food on my table for this coming week. So I wish I could give you something. I wish I could protect you, but we'll go through it together. And even if you make that wrenching decision of your children going back to school, I think we'll learn a lot. I'm not saying it'll automatically will be bad. I'm just saying it's on paper, theoretically, a higher risk because of children and being closer together and not being able to mask all the time. But thankfully, kids generally do well, and if they were to get it, hopefully they'll be monitoring things very closely and minimizing transmission if someone were, God forbid, to be positive. So I know people are making decisions right now. We don't have experience to guide us. So your guess is really as good as mine. Just understand all the pros and cons. And you know your family situation the best. You would have the best gauge of the environment of the school that you're sending your children to, and the kids and the teachers around them. And we'll do our best. I know you will. So, oops, these were old slides. So that's really it. I wanted to thank everybody. I'm sorry for all my technical glitches today. I'm going to my last slide here. Always reminding people of the resource of the chapter and the COVID resource in particular, but Terry herself, please keep your questions coming. Watch your announcements because next week, there'll be a decision about next week. I'm going to be away. My family and I are just getting out of Atlanta, driving. And, getting a well-needed break. So thank you for all your time. So I won't be able to join you guys on Sunday of next week, but there may be another alternative program or not. So be sure to watch the announcements closely about next Sunday. But please keep sending your questions and your suggestions. And I want to hear your take about immunizations. I really do. That's going to be important. Okay. See anything in the chat room? Yeah, the thing about vaccines, and I'm trying to come off as forceful more for myself because I think I've been passive in the past. But I think this time has really shown us of trying to be sensitive to other people's perspective, and it is not completely black or white with the vaccines either. And I admit that there are some unknowns, but I think there's so many unknowns that are as great, or if not greater, that people accept each and every day as part of their lupus treatments. But when it comes to the vaccine, it's like this separate issue that takes on this whole character of its own, and that doesn't make sense to me. So I think we need to be more rational about this. So I think there will still be people that have an issue with the vaccine, and I'm not saying that that's necessarily wrong, but I do want to point out for those that have a very irrational way of approaching it, that you need to acknowledge that. And if we do have an effective COVID vaccine, it would be a shame for you not to potentially consider it if you don't really understand what you're doing. Okay, that's it. Thank you guys. Appreciate the time. Be safe, please. And I'm hearing more and more of some lupus patients actually getting COVID. Fortunately, the ones that I know of are generally doing okay, but please be careful out there. It's definitely out and about.